We're really excited for today. I'm a hospitalist, and recently I was working and I got a call from a colleague who wanted me to evaluate a patient on their service, a non medical service. And my colleague told me that this patient had suddenly developed frequent loose stools, diarrhea. In fact, had 13 bowel movements in the span of 24 hours. Additionally, my colleague shared that this elderly person was having abdominal pain, nausea, and vomiting. The most important thing you can do when you're evaluating a patient is to start by reviewing the vital signs, especially in the hospital setting. And I quickly looked and saw that the heart rate was within normal limits. The blood pressure, however, oh, my cat is coming here to say hi. Sydney, come here. Sydney Palak. Hi. Say hi, Sydney. Say hi. That's Sydney. We have two orange cats, Gino and Sydney. Sydney, I like more than Gino, but I still love Gino. In any case, the vital signs are vital. And I looked at the blood pressure, and the systolics were in the high 90s and diastolics in the low 60s. Now, that measurement alone is relatively low, but what would be more powerful is reviewing the trend of the blood pressure. For instance, if this patient's blood pressure lives around there and now they're having diarrhea, well, I'm less concerned about the severity of the volume loss. However, when I looked at the prior values, the systolic blood pressure was in fact 130 to 140 throughout their hospitalization. So this really concerned me that they're losing so much volume that their blood pressure is lower, they're becoming hypotensive, or there is an infection or something brewing and they're having sepsis. And right away, I knew I had to go see this patient pretty urgently. And that triad of nausea, vomiting, abdominal pain, and loose stools is really signaling the clinician to the GI tract. Now, we don't know what is going on in that GI tract, but everything is yelling the problems in the GI tract. So when I went to evaluate the patient, I asked them how they're feeling, and what they did was they said, I'm having a lot of abdominal pain. So my focus shifted from the loose stools for in that moment, and it became, how do we evaluate abdominal pain? But something really quickly about loose stools. When someone's having acute onset diarrhea, oftentimes it's self-limited and it's due to an infection. It's when diarrhea persists that we sort of step back and start considering either uncommon infections or non-infectious processes like inflammatory bowel disease. So I looked at this patient. He was grabbing his lower abdomen. And the first thing I did was put my stethoscope on the abdomen because I wanted to auscultate to see or to listen. You can't see bowel sounds, but to hear the bowel sounds. You don't need to put your stethoscope in all four quadrants. I'm not sure where that practice came about. You just need to put it in one place, especially if you hear bowel sounds. I put the stethoscope there and I could hear bowel sounds. They didn't seem unusual to me. So then I went for a palpation and I had the patient sort of direct me to where it hurt the most. And when I palpated in that region, I saw the patient grimacing and grabbing their belly. So now in real time, the patient before me, I'm thinking about what is the algorithm or the framework for abdominal pain? Because that algorithm is going to guide my next questions of the patient, but it's also going to guide what my next steps are in diagnosis. So let's go ahead and review our approach to abdominal pain. You can come here to rlrcpsolvers.com. This is behind a paywall, though this particular schema that I'm going to share is available for free on our CP Solvers website. But if we go to start learning and I go down to the GI tract, you'll see there's a lot of frameworks for abdominal pain. And really, I want to start with the overview of abdominal pain. And I think one of the best ways to approach most problems in the hospital is to always have a list of do not miss causes. It doesn't mean you need to test for them, just you need to think of them. Because if you don't think of them, then there's a chance you're going to miss a life threatening diagnosis. And right away, I love this obstruction, perforation, and vascular issues. This patient, they told me they felt like their belly was distended. It didn't feel like that on my examination, and it was soft. And it didn't feel like there was like an acute abdomen or something I needed to call the surgeons for. So then I was like, okay, there's probably something happening within the GI tract, but maybe it's not acutely life threatening, and I have time to think about it. Then you have to approach it, or the best way to approach it is through the quadrants. But there's a limitation in this approach, and that these organs are so closely packed that if you have disease, for example, in the liver, it may cause pain in the center of the belly or the left of the belly because they're just so they're so closely packed that it's just not that specific or sensitive. Though it gives you a clue. And this patient was saying, I'm having pain in the lower abdomen. And if you look at a lot of these causes of abdominal pain, not many of them cause loose stool. And like, for example, GERD, or if you have congestion of the liver from heart failure, it doesn't really cause loose stools. So now I'm incorporating lower abdominal pain with loose stools. Though I paused for a second because I know one of the most telling signs of an obstruction is nausea, vomiting, and the patient's feeling distended. But if I add loose stools, all of a sudden I'm like, wait a minute, could there be inflammation of the bowel? Could this patient have colitis? So that was sort of our framework, but in reality, you can't just think about what the possible causes are. In parallel, you got to think, where is the safest place for the patient and what do I have to do to manage them acutely? And where the patient was located in the hospital, they actually didn't have an IV and they couldn't really be monitored closely for medical problems. So I knew I had to transfer them to a general medicine ward bed, and I knew I had to get an IV. And furthermore, I wanted a CAT scan. So we sort of mobilized personnel. We got an IV in place. As far as the labs that we sent, you don't have to be too hypothesis driven here. We know these patients are going to get a complete blood count because we want to look at the white blood cell count to see if there's any evidence of inflammation. We also know that we're going to get liver chemistry tests because we want to know, is the liver inflamed? Furthermore, we're going to look at the kidney function. And in this particular patient, I wanted stool studies. We have a biofire at our institution where we can sample the stool for the most common culprits of infectious diarrhea. And of course, we're going to send a C. diff to make sure there isn't C. diff colitis. One other thing was that this patient was given loperamide, an anti-motility agent, for their diarrhea. You want to avoid that initially, especially if you're worried about inflammation or something sinister. Because if you give loperamide, for example, and someone's having an obstruction, then that can be problematic. Though in reality, oftentimes when people have obstruction, they're not going to be having 14 bowel movements. So we got those lab tests, and let me share those results with you. Pretty much the CBC was normal. There was no abnormal liver chemistry tests, and the chemistry panel, the kidney function, was totally normal. I also sent an ESR and CRP because this patient had a possible history of ulcerative colitis, possible, not definitive within our system. And the CRP came back elevated, but not so much the ESR. The CRP is a marker of inflammation, as is the ESR. They're both very sensitive, but they're not specific, meaning it doesn't allow you to tell infection from cancer, from autoimmune diseases apart. It just says the body is inflamed. CRP is more short acting, goes up quick, comes down quick. ESR sort of slowly goes up and slowly comes down. So we ended up getting a CAT scan, and let me show you the CAT scan. Now, I'm not a radiologist, but I'm going to do my best to show you the findings that the radiologist interpreted. If you're a radiologist watching this, or you have knowledge in the field of radiology, please share parts where I make a mistake or highlight stuff that I don't identify. The first thing I'm going to do is just bring it right to the beginning and play it once through for you so you can just see it on your own. And then I'll sort of tell you what the radiologist said. And here the CT scan is going. This, by the way, is a transverse view, a horizontal view. We're shooting from the feet up. So the patient's right is going to be on the left of the image. The patient's left is on the right of the image. The higher up you are, you're going to see the chest. And as you go down, you see the spine. All right, so now that you guys have gone through that, let me show you. Right away, I think it's really important that you review images you get in your patients. One, the radiologists are not perfect, but two, and I would say more importantly, you want to see the pathology. Like the pathology, once you see it, it will drive your passion. It will cement that diagnosis in your mind. So I encourage you to review as many images as you possibly can. So right away, right here, we see the heart, right heart, left heart. The right heart is anterior to the left heart and closer to the sternum. Right on the left, we're starting to see the liver. And immediately, what I see is abnormality. Like I'm seeing dots of air and solid material. Remember, solid material is dense. So it seems like it's dense material with air in it. And as I scroll further down, and you'll appreciate, you see how dilated that is? So that is dilated loops of small bowel. Because remember, the small bowel is very long and it's sort of packed in the middle, while the large intestines or the colon sort of goes around the small bowel. So as we come down, we saw that there was dilate, dilated small bowel. And here you're seeing, I believe, the transverse colon, segments of the colon, and air fluid levels. Really, you should never see air fluid levels in the intestines unless they're not contracting well. Because when the intestines, small and large, are contracting well, it's mixing up air, liquid, solid into a homogeneous material. So you should never see separation. You only see separation when the bowels are not contracting, because when they're not contracting, the less dense air separates and it comes to the top. And by the way, here are the kidneys. I just love the kidneys. It's like probably my favorite organ. So as we sort of scroll on down, we're going down, and here you see the vertebra. We're scrolling on down, 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 and now you're starting to see stuff. And what you're starting to see, and you can see appreciate it better here, you see this enhancement of the mucosa. When you have mucosal enhancement, and I think one of the reasons we like to use contrast, it's telling you that it's consistent with inflammation. So inflammation in the intestinal lining at the level of the colon, inflammation equals itis, so that equals colitis. And in part two of this episode, we'll share an easy way to think about the various causes of colitis. And I'm going to come down here and I want to show you something else that the radiologist commented on right here. And you can probably see some enhancement here. The rectum is posterior to the bladder, and that rectal enhancement would be itis of the rectum, proctitis. So this patient has evidence of proctocolitis with an ileus. So in part two, I want you to think about and write your comments below.
That's a wrap,
What is your approach to proctocolitis? What's your approach to ileus? Are the two linked or not?